Okay, our next three speakers are all coming to us from not this room. I believe the next speaker is Dr. Strupp. Is that correct? In Germany. So I believe he's taking control of the screen as I speak. Dr. Strupp, is this the order we're going in? Who's next?
So the first speaker is going to be Marc Patterson from Mayo Clinic.
Great. Let me just very briefly say the names on the screen. You have a professor, not an associate professor, not a doctor, a full professor of neurology from Mayo. You have a full professor of biochemistry from Oxford, and you have a full professor of a lot of stuff, which I need to put my glasses on to read, from Germany. So we have three exceptional professors who are all going to talk to us about now. They are going to split a lot of hairs on that word, and that is Tanganil. So we've heard a lot about Tanganil, NAL as opposed to NAL. I'll let them explain. But this is very, very interesting stuff from three. You couldn't have three better speakers on this topic. So I'm going to shut up. I'm going to thank them for agreeing to do this, and I'm going to hand it over to Professor Patterson, and with great thanks for doing this.
Well, thank you very much for the opportunity to speak today. I've learned a little bit about Syngap today and from some of the great work you've been doing, and I hope we'll be able to contribute as well. We're going to talk to you about the clinical trials that have been done of the L-enantiomer, the left-handed form of acetyl-leucine. You'll learn more about this from Platt explaining the difference between right and left-handed forms of molecules and why this particular molecule was studied specifically. We're going to talk to you about the studies that have been done in most depth, which have been in Niemann-Pick disease type C, but we'll also cover some additional work that Michael Strupp has done. And Professor Strupp has really been a tremendous clinical leader in bringing this drug to different populations and showing its potential benefit. We'll skip over this next slide, I think, because this is for everyone. These are our disclosures, and my colleagues will make theirs as well. And just to move on, to give you a little background, for those of you who may not be familiar with it, Niemann-Pick disease type C is a lysosomal disease. That's a family of about 70 diseases, all of which involve the accumulation of substrate in the lysosomes, in most cases because of deficiency of an enzyme. In this case, there is not an enzyme deficiency, but rather there is a trafficking defect, so that the system of endosomes and lysosomes, which move large molecules around the cell, suffer a traffic block with accumulation, particularly of lipids in the peripheral tissues in the brain. This leads to progressive neurological symptoms and ultimately to a shortened lifespan. This is a very rare disease. Its incidence is about 1 in 100,000 per year. It's been found in every population in which it's been sought, and it's actually associated with two genes. The NPC1 gene is mutated in about 95% of cases, and the NPC2 gene in the rest. Until September of this year, there was no approved therapy in the United States for this disease. Next slide, please. And so when it comes to approaches to therapy for Niemann-Pick disease type C, of course, it's a genetic disease and gene therapy would be ideal, but that has not yet reached the stage of a clinical trial. It's been studied in animal models. You might say, perhaps we could replace the deficient protein, but this protein is not an enzyme. It's a protein which is expressed in a membrane, and for this reason, it's not practical to replace it within the cell. And so there have been a variety of approaches looking at different targets. One has been to reduce the amount of cholesterol, one of the lipids that accumulates within the cell. 30 years ago, we did a study when I was at NIH looking at cholesterol-lowering drugs, which lowered cholesterol in the tissues but had no effect on neurological disease. More recently, compounds called cyclodextrins have been found to affect and lower cholesterol levels in the brain and cause some redistribution. A trial was performed which unfortunately failed, but that approach is still being used. Miglustat, a drug which was largely developed by Platt and her colleagues at Oxford in the 1990s, reduces the synthesis of a number of the molecules that accumulate, the so-called glycosphingolipids. and that has been approved in most of the world and used off-label in the US. A number of other approaches, such as inhibiting histone deacetylase to cause enhanced expression of the deficient protein. Sometimes if a protein is deficient, just making more of it can overcome the defect. Antioxidants have been studied without benefit. Enhanced expression of heat shock protein and lysosomal function using arimoclomol has been studied, and that agent has been approved recently together with miglustat, or I should say only in combination with miglustat. But the agent we're focusing on today is N-Acetyl-L-Leucine, which Fran Platt's work has shown enhances mitochondrial energy production, lysosomal function, and damps down inflammation. Next slide, and now I'd like to hand over to Professor Fran Platt, who is joining us from Oxford in the United Kingdom.
Thank you, Mark. It's really a pleasure to be here talking about this drug. I hope you can hear me okay. So I'm going to give you a little overview about acetyl-leucine, and you're familiar with it as Tangenil, which, as Mark said, is a left and a right-handed version of this modified amino acid. So leucine is a natural amino acid. When it's acetylated, it converts it into a drug, and we've been trying to work out how that acetylation really makes this into a neuromodulatory drug. So acetylation makes the compound a substrate for a different transporter. Normal leucine is transported into cells through an L-amino acid transporter, but the acetylation makes it a substrate for the monocarboxylate transporters, which really results in the very high levels of delivery of the drug into the cells of the body, much more than you can achieve with leucine in its unmodified form. Now, Tangenil has been around in France since the 1950s, and it's this D and L enantiomer mixture. What that means is there's two mirror images of the amino acid. It's like having your right and left hands. They are mirror images, but they have slightly different properties. And we've discovered that it's the L enantiomer that is the active form of this drug, and that's why it's the L enantiomer that has progressed to clinical trials and approval. Now, as Marc said, we've been working on the mechanism of action of this drug. I think there's still more to learn, but what we have discovered is that it's modulating a number of key cellular functions. Now, if you look at this schematic on the left, this is just illustrating that the drug has the ability to go through the monocarboxylate transporters into cells. When it gets into the cell, it's deacylated, and leucine is actually metabolized and modulates a number of metabolic pathways in the cell. And in particular, it can modify gene expression, it can change mitochondrial metabolism, and in particular, it has the ability to rebalance glucose metabolism when it's dysregulated in the brain. And it has a knock-on effect on the lysosome, improving its function and reducing some of those lipids that Marc mentioned that are stored. It also has the ability to modulate membrane potential in excitable membranes like we have in neurons. I won't go through all of the text on this slide, but it's just to say that this preference for being transported into the cell via monocarboxylate transporters is really the key to how this drug works. It's essentially a prodrug that's modified within the cell to release the active form, which is the natural amino acid. Next slide. So we've done some experiments looking at trying to understand the key effects in Niemann-Pick C, and we've used a mouse model of this disease that recapitulates the clinical signs. And what we found was that in Niemann-Pick C, we have altered glucose metabolism in the brain, where there's not very much processing of glucose to completeness through oxidative phosphorylation, so you don't produce as much energy. Instead, you produce, you have a dominance of glycolysis, and also lactate builds up. And what we found that's quite remarkable about this drug is it's able to activate one of the gatekeeper enzymes that allows flux through what's called the Krebs cycle, which is really the route to generating much more energy for cells. And by doing so, this helps restore neuronal function. Neurons that are struggling because of the disease burden actually survive much longer. We've also studied a second disease called Santoff disease, or GM2 gangliosidosis. This has actually a different form of energy metabolism defect in the brain, but it is also restored by exposure to N-Acetyl-Leucine. And these are just two key enzymes that are perturbed in these systems. And these graphs are just showing you that in the absence of the drug, they are abnormal. And when you treat them with the acetyl-leucine, it helps restore balance in the system. So if you like, this is a metabolic enhancing drug. And one of the really remarkable things that we found was that it also has a collateral effect on the lysosome. It reduces the levels of several stored lipids in this disease. This graph on the left is just showing 4 of those, which is sphingosine, a family of molecules called GSLs, which are glycosylated lipids, cholesterol, as Marc mentioned, and also we're measuring lysosomal volume. All of those in orange are elevated in the disease relative to the dark blue, which is the healthy wild-type mice. And you can see in the paler blue that there is a restoration, a partial restoration of those lipid levels in response to acetyl-leucine treatment. In the brains of these mice, they have active neurodegeneration and neuroinflammation. And if you look at this little black panel on the right, you can see in the wild-type animals on the left, you don't have degeneration. Those red lines in the top are sort of delineating the cerebellum, showing a normal brain, and there's no neuroinflammation, which is in the lower panel in green. So you can't see any green cells there. Whereas in our untreated Niemann-Pick C mice, you can see that some of the lobules of the cerebellum have lost that red stain. They've lost Purkinje neurons. And in below, you can see a lot of green cells, which are activated macrophage-like cells called microglia, which are clearing those dying cells. And you can see when you treat these mice with acetyl-leucine, you have much less neuroinflammation, and also you protect and slow the rate of Purkinje cell loss. And that's just quantified over on the right. So this drug is reducing neuroinflammation and also improving the energetics of the neurons in the brain. Now, in patients with Niemann-Pick C, cerebellar ataxia is a prominent sign, and the mouse model has exactly the same feature. And what we were able to show was that if you treat these mice when they are already symptomatic and displaying ataxia, that you can restore you can reduce the symptoms of ataxia. And we've done this experiment in 2 ways. So we're looking at untreated mice, wild-type mice on the left. We've got the orange Niemann-Pick C mice showing a much higher score. This means that they're ataxic. If you treat those animals when they've already got established ataxia just for 1 week, it's the next group of points, which is much closer to the healthy situation. And if you treat pre-symptomatically, which is the group on the right, the result is even better. So we were able to recapitulate at the same doses in the clinic in the mouse. We found the same positive benefit on cerebellar ataxia. Now, that experiment where we treated before symptom onset also revealed another thing about this drug, which is the L enantiomer selectively prolongs survival in these mice, because what it's doing is it's slowing disease progression, and these animals are living longer. So we've got 2 benefits. One is a rapid improvement in symptoms of ataxia, and the other is a prolongation of life because we're slowing the rates of disease progression. And I think on the next slide, we've got a little video to run. These are 2 animals. They're littermates. They're from the same pregnancy. They're the same age. But the mouse on the left, you can see he has poor coat condition. It's quite wobbly. Whereas the treated animal, which is the one that's just going to come and walk down towards you, you can see it's much healthier looking animal, much more active, and it's exploring its environment. Its ataxia burden is much lower. And this mouse looks like a mouse that's about a week to 10 days younger than its litter mate, because again, we've slowed disease progression by pre-treating this animal. So this, I think, gives you more of a flavor for the functional benefits that we're seeing in the mouse model as a result of these changes in energy metabolism, neuronal membrane potential, and also this reduction in the neuroinflammatory process that's going on in the brain. So I'm now going to hand over to Michael Strupp, who'll talk about the clinical findings.
Thank you, Fran. Thank you, Marc. I'm joining you currently from India. So here it's 3 o'clock in the morning, but I noticed that there are participants from Australia, and maybe it's even worse. So I'm going to talk about 3 different topics. As a clinician, on the phase 2 trial and an observational long-term study, data will be presented later by Marc. The major focus will be on the design, study population, results, subgroup analysis, and safety of our successful phase 3 trial, which was published in the New England Journal in February this year. And then I'm going to present you some exciting news, because N-Acetyl-Leucine has been able to show that it prevents the onset of Parkinson's disease, and this can be already explained by the mechanisms which were presented by Fran. So let's start with our observational and phase 2b trials using N-Acetyl-L-Leucine for NPC. On the left side, you see the results of the phase 2b trial. In this trial, patients were treated with N-Acetyl-L-Leucine for 6 weeks, and then we had a 6-week washout period. And in blue, you see the improvement of the patients, and here in yellow, the deterioration after the washout period. So there were clear clinical effects. On the right hand, you see a long-term observational study in patients with NPC over many, many years. You see there was a constant deterioration before treatment, and when patients were receiving N-Acetyl-Leucine, there was either a stabilization or even an improvement, which is supported by the extension trial of the phase 3 study, which will be presented later by Marc Patterson. And here you see an example of a 14-year-old patient performing the 9-hole pegboard test, which is a standard test to examine hand and arm coordination. On the left hand, you see this girl is hardly able to perform anything. In the center, she's on treatment, and you can see how elegantly she's doing this test. And after washout, you see the patient is in the devastating condition as before. This is now the simple and straightforward trial design of our phase 3 randomized controlled study. So it's very simple. Patients were on treatment for 12 weeks and then shifted to the placebo group and vice versa. So we had 13 trial sites in 8 countries. The dosage of N-Acetyl-L-Leucine, which is the active ingredient, was 4 grams per day. And I'd like already mention that there has been an extension trial which showed a neuroprotective effect. The primary endpoint of this trial is a standardized endpoint, the so-called spinocerebellar ataxia, the SARA, the SARA score, the scale for the assessment and rating of ataxia. We also had other secondary endpoints, including quality of life studies. The study population was a broad range of ages from 5 to 67 years. The diagnosis was genetically proven, and patients were moderately impaired by the disease, and we recruited 60 patients in those days in a COVID environment within less than 3 months. And this slide here shows you the major results. In red, the primary endpoint scale for the assessment and rating of ataxia, and there was a clinically meaningful improvement versus placebo in the treatment group. Secondly, all the secondary endpoints, including the investigators, the caregivers, and the patient's clinical global impression of improvement, showed also clinically meaningful and statistically significant effects. We also performed a subgroup analysis depending on age, gender, age of symptom onset, and severity. And everything here on the left side shows a consistent improvement over all subgroups. And this is, of course, a strong rationale for the use of acetyl-L-leucine in all patients with NPC. When one runs a clinical trial, one has to be, of course, concerned about safety issues. And here you see the very few adverse events which were observed. To summarize this briefly up, first, there was no serious adverse reaction, and the adverse events between the groups placebo and on drug were similar and only very transient. This finally led to the approval of acetyl-L-leucine by the FDA September 24th this year. It's levacetyl-leucine, and the term is Agnersa. And here I'd like to mention that we do not recommend to use the racemate anymore. Why? First, the racemate was approved for adults only. Secondly, the racemate was approved for a short-term treatment of a maximum of 10 days. Thirdly, the racemate contains the D form, which is not active, and as we showed in a previous publication by Grant Churchill from Oxford, it can also have an accumulation within the cells, so in the long term, it may harm cells. And since this drug, acetyl-L-leucine Agnersa, is now approved, it will be the drug of choice, namely because there's no other approved treatment also for Syngap. And we strongly recommend that one should start individual cases of off-label use. And maybe if we see a clinical benefit in a patient, this can also be paid for by the health insurance companies. So to summarize the key findings of these trials, so acetyl-L-leucine Agnersa led to a significant, and that's important, clinically meaningful improvement versus placebo on all endpoints. We'd like to point out that not only ataxia is improved, but many other neurological signs and symptoms, namely also cognition, memory, and behavior. And all in all, this improves the patient's function and quality of life, but also the caregiver's quality of life. When the treatment was stopped, there was a deterioration within a few weeks. And this is very important for compliance and consistence of patients, because patients and their caregivers and parents notice when I stop the medication, the symptoms become worse. We observed an improvement over all subgroups. The drug is safe and it has a disease-modifying effect, as will be shown later. Now, for 3 minutes, we are going to make a sensational observation detour. This paper we published in Nature Communication, September 2nd this year. And in this paper, we could demonstrate that this molecule reverses the onset of another neurodegenerative disease, Parkinson's disease. In Parkinson's disease, we are in a very exquisite position because many patients who will later on develop Parkinson's disease present with so-called prodromal symptoms, in particular, so-called REM sleep behavior disorders. What is this? This is characterized by very aggressive and threatening dreams, which are enacted by patients, which may, in the worst case, lead to the fact that they kill their spouse during the night. And this is specific and a common prodromal phenotype of Parkinson's disease. And if patients do have REM sleep behavior disorder, the risk of a conversion to manifest Parkinson's disease is 85% over a period of about 10 to 15 years. And now I'd like to guide you through this really spectacular slide. What you see here in yellow is the activity of the dopamine transporter in the brain. And in Syngap, we also learned that there is, for instance, an impaired function of the dopamine 1 receptor. So what you see here in patients in this pre-treatment long-term observational study from 2013 to 2019, there's a deterioration of the function of the dopaminergic system from 1.88 to 1.22 in this patient. Then this individual was treated for 22 months by N-Acetyl-Leucine. And you can see here that the function of this essential system is now better than 10 years before, which is absolutely spectacular. In patient 2, you see similar findings, went down in 2020 to 1.42 and got up to 1.72. And from this patient, we do have more recent findings. So the function went up to 2.26 in the dopamine system, which is now in the normal range. And these patients did not develop manifest Parkinson's syndrome with motor symptoms. So N-Acetyl-Leucine has improved the symptoms of REM sleep behavior disorder, which is nice for the patients and the spouse. But even more impressive, it reverses the loss of dopamine transporters in the necrostriatal system. And thereby, we could demonstrate that it reverses the progression and patients will not develop Parkinson's disease. And there are a lot of ongoing studies soon, which will be run in the US and also in Europe. Now I'd like to hand over again to Marc Patterson, who is going to talk about the extension phase of the phase 3 trial.
Thank you very much, Michael. I wonder if we could move to the next slide. This just recapitulates what you've already heard from Professor Strupp. That is the original study of patients to establish their baseline condition, then the randomized double-blind crossover trial, which you heard about. And now I'm going to talk to you about the extension phase of the study, for which there's data now actually going out to 18 months or more, but for which we have some nice 12 and 18-month data. So this extension phase was available to all of the patients who completed the randomized double-blind controlled parent study. 55 patients enrolled in this extension phase. All of these patients had a genetically confirmed diagnosis. About 85% of them were taking miglustat. I mentioned to you that in the European Union and most countries around the world, miglustat is approved for Niemann-Pick disease type C. It's not approved for this indication in the US, but even here, 70 or 80% of patients use this drug off-label. So it's really standard of care. Now, you heard that the main outcome measure in the original study was the scale for the assessment and rating of ataxia, or the SRF scale. For this longer-term extension study, we used another purpose-designed scale called the NPC Clinical Severity Scale, specifically the 5-domain scale, which has previously been validated and used in other studies. And for this scale, a 1-point change or more in the 5-domain scale is regarded as clinically meaningful. And that determination of clinical meaningfulness was made by parents, caregivers, and clinicians working together. Next slide, please. So this shows you in summary form the 12-month outcome data. And just to show you the graph on the right, the red line shows you the rate of progression over time in a natural history cohort of 36 patients who showed a mean 1.5 point progression. So they deteriorated over that time. This is what we would normally anticipate. Here in the N-Acetyl-L-Leucine group shown in the green line, we see that the rate of progression is negative 0.32 points. In other words, this represents improvement. So again, the mean change in the intervention group was minus 0.32. In the historical cohort, it was 1.5. Mean difference is 1.82, nearly 2 points. And if you will, you can calculate this as 121% reduction in disease progression or a 21% improvement. And of note, the N-Acetyl-L-Leucine was effective with or without miglustat. And as it happened, most patients were on miglustat and they had a net stability. The patients who did not receive miglustat actually had a greater positive change, which is worth bearing in mind. We can't overinterpret that because the numbers are relatively small, but it is very clear. There's clear evidence of improvement and maintained improvement in the group treated with N-Acetyl-L-Leucine compared to the historical cohort. And we have a lot of data from various historical cohorts which basically support this interpretation. Next slide, please. We should also note that the SARA also demonstrated continued improvement. So after the 12-week interventional study, there was an improvement of 1.97 points. After 12 months, the improvement was 1.92 points. In other words, that improvement was maintained after 12 months. Next slide, please. So just to summarize the key findings of the extension phase, there was evidence of statistically significant and clinically meaningful improvement in the intervention group versus the natural history cohort using the 5-domain NPC clinical severity scale. And as we've seen, this calculates to 121% reduction in annual disease progression. The treatment with the N-Acetyl-L-Leucine prevented worsening and even showed some improvement in a number of patients, reflecting a potential neuroprotective and disease-modifying benefit. The improvement in the neurological symptoms and signs demonstrated with NAL versus placebo was also seen in the SARA scale, maintaining the benefit that was demonstrated in the randomized double-blind controlled trial. The drug was effective with or without background miglustat use. It was well tolerated with no drug-related or serious adverse reactions reported. So our conclusion is, in light of its very clear efficacy and safety profile, levoacetylleucine or N-Acetyl-L-Leucine should be a foundational therapy for the treatment of Niemann-Pick disease type C. Next slide, please. So that completes our whirlwind presentation. I would like to make a final acknowledgement, though, and specifically and most importantly, acknowledge the contributions of patients and families. Those of us who work in clinical trials are very much aware of the sacrifices and dedication that are asked from families, and we're very grateful to that, particularly since part of this study, or these studies, were conducted during the pandemic. And as you can see, there's a very large international group of investigators who participated in these studies. So I think that brings our presentation to a close, but we're very happy to take questions from the audience and specifically, I imagine, about potential relevance of these findings to Syngap. Thank you very much again for the chance to speak with you.
Thank you, all three of you, for speaking and for, can you guys hear me? Is the audio?
Yes.
Okay, great. Thank you very much, Dr. Patterson. As you know, or as you might have heard, our community did stumble across Tanganel some time ago and have had impressive results in a number of patients. And now IntraBio has marketed the drug in the States, but in these early days, getting access to that drug, or at least access from a payment point of view, is going to be tricky. So I guess I have two questions. You might have covered this a little bit, but just to be Clear. Is your suggestion that people should go to their neurologist and armed with this presentation, ask for them to try to write it off label and see what happens? That's question one. And then question two is, we have colleagues in the room from Austria and Argentina and Australia and other places. How is the global rollout? How is global access for this at the moment? And which countries do you foresee it being available in over time?
Yeah, thank you. I'll make the first stab at that question since I'm the presenter who's practicing in the US. As you know, I shouldn't assume as you know. Let me just say this. Drugs are available in the United States if they are approved for any indication. If the drug is being prescribed for an indication which is approved by the Food and Drug Administration, then generally insurance will cover it. Now, I give some caveats there because one can never make guarantees about health insurance coverage, and they often make it difficult. But a physician can prescribe any drug which is approved by the FDA for an indication other than the approved indication. That's perfectly legal and ethical, as long as the physician believes that there is a likelihood of benefit exceeding any potential risk of prescribing the drug in that situation. I did want to emphasize that that is an important legal and ethical consideration. I can certainly tell you that there are a number of patients with disorders other than Niemann-Pick disease type C who have been prescribed this medication since its approval, and I can say that because I have prescribed it to a number of patients with other disorders for which I think there is a rationale for using this drug, and in whom I think that the risk of doing so is minimal compared to the potential benefit. Now, it's always most helpful if you're dealing with an insurance company to have data that you can present to the insurance company to support the off-label use of medication. I've had most experience with that with miglustat, which you've heard about as a drug which is approved in the United States. It's for certain patients with Gaucher disease, but not approved for Niemann-Pick disease type C. But the majority of patients in the United States with Niemann-Pick disease type C are receiving miglustat covered by insurance because we have been able to produce a large body of evidence published in the peer-reviewed literature that shows evidence of efficacy. In fact, the largest study we were able to put together, which required international cooperation and data sets over many years, showed that it increases survival by a factor of 5 to 10 years, depending on whether one measured from date of onset or date of diagnosis, because as with many of these disorders in the past, there's been a significant delay in diagnosis. So that's some background. Now, I hesitate to say too much more because I'm speaking to a room full of experts on Syngap associated encephalopathies, and I am no expert. I am aware that this is a spectrum disorder. Many patients have dominant truncating mutations. The gene product is very much involved in synaptic function, the formation of dendrites. Many patients have seizures, I think particularly eyelid myoclonia, or other specific subtype of seizures. So I'm familiar with that fact. And one would anticipate that in a disorder of this sort, that there would be disordered energy generation given the nature of the underlying defect. I'm not aware that there's a great deal that's been published specifically on that subject. Now, some members of your group were very kind to share the report that has been prepared. I must say, a very impressive and very professional report looking at case studies of patients with Syngap and other neurodevelopmental disorders who've been exposed to N-Acetyl-L-Leucine. And I think the data are very impressive. There have been responses which have been quite rapid, which is what we've seen in the clinical trials with Niemann-Pick disease type C, and quite dramatic in a number of cases. Not everybody responds, but then I would anticipate in a spectrum disorder where there are likely multiple downstream effects of the mutation that you would have quite a number of different mechanisms at play. That was a very long answer to your question, but what I would say to summarize is, and I'll let Dr. Strupp speak in a minute, is that it is quite legal. It is very reasonable for you to have a conversation with your neurologist or whoever your primary physician managing the disorder overall is about potential off-label use and talking about what data is available to support that and the rationale for doing so. Professor Strupp.
Thank you, Marc. You have mentioned countries outside the US. So we expect to get approval for Aqneursa in Europe in February next year by the European Medical Association. And then we will have the same good situation as in the United States. When it comes to the mechanism of action and Syngap, it has been demonstrated that acetyl-leucine normalizes membrane potential and excitability of neurons. So there are neurons which are hyperactive and other neurons which are hypoactive. We all know these neuronal circuits which can lead to an imbalance in many other systems in the brain. And acetyl-leucine normalizes excitability and thereby also normalizes transmission of all neurotransmitters, namely also, as you have seen in the dopaminergic system, which is relevant also for behavior and motivation and also cognition in these patients. The other thing is, as I said before, once a drug is approved in a country, that's another reason not to give a non-approved drug in your country. It contains gluten, and 20% of the population has a gluten allergy, so it's less well tolerated. And maybe, but I'm just speculating, that some of the side effects which were observed in your case study are related to the deform, which accumulates inside the cells and even makes the effect of acetyl-leucine lower. So our clear recommendation, and I echo that what Marc has said, is that doctors should prescribe this molecule. And then you can argue with the health insurance companies. And as was demonstrated for miglustat, there's a good chance that this can be covered by your health insurance companies currently in the US and hopefully by the beginning of next year also in European countries.
We have two medical questions. One is, have you seen any interactions with particular interactions with valproic acid and similar medications like valproic? And the second question is the dose that you guys have in Niemann-Pick is quite high. And we have seen that in Syngap, it requires, or we see changes with half of the dose, I would say, or 1/3 of the dose. That is the dose that is used in France with Tanganil. Those are my two questions, the dose and the interactions with other medications.
Yep.
So in the clinical studies, we did not see an interaction with any other medication. And this was a controlled trial. And as you know, a patient with NPC can also have seizures. So there were patients on this medication, and we didn't see an interaction. I'm fully aware of the question of the dosage. The approved dosage for acetyl-L-Leucine in adults is 4 grams per day. And in children, of course, the dosage has to be adjusted according to the body weight. And I'm aware of these very few cases where you saw an interaction evidently with other drugs, and also the question of the dosing in patients with Syngap. So my pragmatic recommendation would be to start with a low dosage, what we often do for other medications too, maybe half of the dosage, or in children, 1/4 of the dosage, and then you can titrate according to the effects you see in your patients. There's no need to jump in with a full dosage. And secondly, we have to learn about the dosage of this effective molecule in various diseases, because as you know, these are very complex diseases based on the pathophysiology, and this should be more individualized, precision, personalized medicine, starting with a low dosage.
I wonder if I could ask Professor Platt just to comment specifically about valproic acid and taking into account the fact that the controlled trial didn't show evidence of interactions, but is there any concern about competition for the organic acid transporters or monocarboxylate transporters by drugs like valproate or similar drugs, at least as a potential confounder for this
Yes,
drug?
I mean, I think theoretically, any drug that uses the monocarboxylate transporter system could potentially have a competitive effect, or you may damp down the effects of either drug if they're co-administered. But I would say that there are 14 family members of the monocarboxylate transport system. We know that MCT1 certainly can transport acetyl-Leucine, but I think the devil will be in the detail over exactly which of these transporters at which sites in the body are the primary ones for different classes of drugs. So I think it's going to be quite a complex system. What we can say, however, is that if you compare the D and the L acetyl-Leucine together, we find that the D competes for the uptake of L. So this goes back to the point that Michael was making, is that we don't advocate taking the racemic mixture now that the acetyl-Leucine's been approved, because the D enantiomer, not only is it not metabolized and can build up, but it also competes with the L. So just taking the pure L really maximizes the effect. I think going back to the drug interaction thing, I think that's something that we will continue to investigate, and we haven't seen any or haven't had reports of any clear-cut effects from the clinical studies so far. But I think it is a theoretical possibility, but a complex possibility because of the large number of these different transporter isoforms.
If I may add from a clinical point of view, of course, in the meantime, we have had a lot of patients who switched from the racemate to the L form with various neurological diseases. And we have noticed that the benefit of the L form is considerably higher. Also patients who have, for instance, cognitive impairment. And I remember one patient from Florida, he was on the racemate before, and he's now on 4 grams of N-Acetyl-L-Leucine, and his spouse is very excited how much his cognitive function has improved with the L form.
That's incredible and a great point to stop. I mean, for context for you three. Last year at our meeting, we had Professor Chow from Utah, who is in the room now, share that N-Acetyl-L-Leucine hit on a drug screen, and shortly after that meeting, Virginie, who was sitting next to me, ordered Tanganil and started giving it to her son. And so a year later, have the three of you on screen and to be hearing about this and to have the molecule approved is incredibly exciting. So Professor Strupp and Professor Platt, it's great to see you again. Professor Patterson, it's nice to meet you and look forward to hearing from us as you are stateside. And I wish we had more time, but we have a schedule that we are dogmatically following. So thank you all for your time, especially those of you dialing in late from Europe. And we'll look forward to talking to you again soon. Thank you.
Thank you. Bye-bye.
Thank you. Thanks very much.
Thank you.